Everyone, welcome to the Journal Club for this evening. So my name is Zwar. I think most people know me. I'm Executive Dean, Faculty of Health Science and Medicine at Bond Uni, and I'd like to start by acknowledging traditional custodians of the various lands on which we meet, and Aboriginal elders past, present and emerging. And we have here to help us today Professor John Emery from University of Melbourne, who many of you would know. John's done a lot of work on cancer in general practice or primary care, and also about genetics and the application of genetics, and was part of the Red Book group that looked at that topic as part of our recent update of the, I think, the 10th edition of the Red Book. And Loai Albarqouni is from the Institute of Evidence-Based Healthcare, who helps us get through the article without too much discomfort, guides us through it with great skill. And Ali Davidson, of course, manages the Practice-Based Research Network very capably. So we might get underway. What we're going to do first is I'm going to present a brief case study to kind of set the scene. And then we will go to Loai to take us through the article that was in the Medical Journal of Australia. And then we'll open it up for discussion with John's input into this and what it means for general practice. The passcode, if anyone's having trouble, is GoldNet, all lowercase, all one word. I guess I'm saying that to people already on, so you're probably not having too much trouble. That's a little... Hi, Kylie. Nice to see you. So I guess I'll start with this case study, which is based on someone I saw in practice. Thanks, Nick. So a 51-year-old man, he'd actually had been living in the United States for quite a while and come back to Australia, and that's sort of relevant to the story. Non-smoker, just very very safe level of alcohol. Past history of migraines, irritable bowel syndrome. There's his weight and BMI, blood pressure, all unremarkable. The interesting thing that he mentioned in the first consultation I had with him was he had an older brother diagnosed with early stage colorectal cancer at age 59. Unfortunately, I think it had surgery and was fine. It didn't need any further treatment. And he had the only other family history of cancer he was aware of was his dad, who was diagnosed with prostate cancer at age 78, and his dad's still alive. Next slide. Next slide. Thanks, Ali. So just to remind, sorry this doesn't come out very clearly, but this is the preventive activities over the life cycle chart for adults, just as a reminder of the Red Book. And of course, for of this age, colorectal cancer, prostate cancer, and skin cancer would all be things that we were thinking about. You can see them there. And he's in the age group for us to be thinking about colorectal cancer and prostate cancer, and of course also thinking about his risk of skin cancer as well. And they're the is those cancer risks. So next slide, thanks, Ali. So I did do some investigations as part of this. He's wanting a checkup, and you can see his lipids were very good. He had a normal PSA, and of course we had an evidence-based discussion about whether he wanted to have that and the pros and cons, but he did want to have it. Unfortunately, it was well less than 3. His HbA1c was very slightly elevated at 5.6, and we've had a discussion since about diet and exercise. Because that's in, if you believe in pre-diabetes, that's just into the pre-diabetes range. And he did do a fecal alcohol blood, and that was negative. But he asked if he should be tested for Lynch syndrome. And the reason was that someone in the United States had suggested that to his brother after his diagnosis for some reason that our patient wasn't clear about, and nor was I clear about. And also in the United States, he'd been talked in by someone to having a whole body MRI scan done. And that showed some cysts in his liver. And then someone had said, oh, you've got cysts in your liver, you should have the screens for carcinoembryonic antigen, alpha-fetoprotein, no evidence that I'm aware that that is necessary, but he firmly believed he should have it done. And so we did do those two things, and unfortunately they were both normal. Subsequent to this, he went off and had a skin check because he had grown up in Australia, and the dermatologist found a BCC, which he removed. So we covered off on the skin one as well. So that's the case. And I was not sure at all about whether he needed any further testing for Lynch syndrome. So we'll see what comes out of tonight. We'll come back to the case at the end. So thanks, We might hand to Loai now to take us through the article.
Thanks, Nick. That's really interesting to pick up the article. So I think the link to the article has been distributed, but just sharing a few slides just to help us or guide us through the article. Is that sharing now? Yep. So this is it's a different than usual. So usually we do kind of a systematic review or research article, but this time we are doing kind of an opinion-based or commentary article, perspective article, looking at the DNA screening for those three diseases. So just if anyone has read the article, what's kind of the main point that you got out of the article? What's the takeaway message after reading this 1 page or 1.5 page? Anyone?
Well, to me, it was an argument for a population based screening approach to some of these reasonably common reasonably common, not rare genetic cancers.
Yeah, I think that's what I also got. So this is kind of the message that I got. That's one of this sentence. What's the main thing that I got from this article? So they are asking for criteria-free, population-based approach to genetic testing, population DNA screening, using low-cost testing for preventing. That's kind of for asymptomatic healthy adults, even not the similar patients like Nick presented. It's kind of population-based for anyone asymptomatic. Do the DNA testing for those disease to identify people at high risk for the condition. And because this is not a research article, I was thinking how we can go through it. And I thought that using that Wilson and Younger classical kind of screening criteria, like criteria for screening tests, could be helpful to guide us what's kind of making reasonable to ask for a screening intervention or screening test. And those kind of the criteria that I think the WHO kind of looking at. So this is 10 criteria, and there is modified one. But the 10 criteria, that first, it needs to be to screen, to have a good screening program. It needs to be a screening for an important health problem, not a trivial one. It should have an accepted treatment for patients with recognized disease. There should be facilities for the diagnosis and treatment available. So you shouldn't ask for something that can't be actually kind of done within the healthcare system. And there should be a recognized latent or asymptomatic stage so that you can catch the disease before it manifests, before being symptomatic. And there should be a suitable test or examination that have a good kind of test characteristic that can be reliable to tag or to screen. And this should be unacceptable to the population. And also the natural history of the condition should be well understood. And the 8th one is should be an agreed policy to whom should be screened or tested. And the 9th about the cost of that case finding should be cost effective. So I was thinking, let's go through those kind of some of those main tests and look what's their argument, whether that makes sense about those tests or not. And we will discuss that later in detail. So the first point about an important health problem, I think they are talking about 3 main conditions: the Lynch syndrome, the hereditary breast ovarian cancer, and the familial hypercholesterolemia. And they mentioned that this is about 1.3%, I think, of the general population. So it's kind of, it's not trivial. So out of 100, there's more than one adult population that have that genetic testing. So I think there could be some kind of reasonable, important health problem. So the second one, there should be an acceptable treatment. And adding to that, in the modified one, there should be a scientific evidence supporting that this screening program is effective. And just to highlight for this one, that a screening program is not only about the test characteristic, but also should be a program or intervention program. And ideally, any intervention program should be evaluated using an RT, randomized controlled trial, where you randomize the population of interest to either screen them and treat them accordingly, or not screen them and treat them whenever they have their usual presentation, and look at patient-important outcome. So it's not only about the characteristic of this, but as a whole, as a package, the screening package, whether that's important to reduce or to improve the patient-important outcome. And looking at the argument, there is no, and also I investigated the references that they have been cited. There's no randomized controlled trial evidence showing that testing and intervention can lead to reduce in patient-important outcome. So whatever here, there's this risk reduction mastectomy or risk reduction procedures is talking about most of them talking about observational studies about people that have those genes, those kind of genetic mutations, and following them up with when they have those risk reduction procedures, they will be lowering the risk of having the condition. But there is no comparative randomized trial showing that it's effective in these patient-important outcomes, especially the overall mortality. That's as far as I'm aware. So here there could be an argument whether there's an effective, acceptable treatment. For the facility for diagnosis and that latent, I think there's no kind of, I think they have done some kind of modeling cost effectiveness studies about, but they are still waiting for that large pilot studies, and they have made it clear that they are still waiting whether there's enough facilities to screen the whole population. And that's one of the studies they are underway to test that DNA, I think, screen. About the test characteristic and suitable test or examination and the natural history, I think that's an important generally, but the most important here I found in the DNA, the penetratability of the condition. And so the idea is that with having the gene mutation, all of them will have the condition itself. And I think they mentioned, and from reading some of the references, all those three conditions have incomplete penetrance. That means not all the people that have this mutation will eventually have the cancer or the condition. So that will affect this characteristic, but also affect the natural history. And the cost they have here, they have done some kind of modeling about the cost. But just a point that this modeling is not based on randomized trial evidence. It's based on kind of just estimation and modeling about the cost and the case finding. So they say that at a cost, the test, if the test cost or the cost of each test around $200, the saving from the cancer prevention outweigh these costs. So they estimated there are around 2,500 cancer can be prevented, and over 1,200 lives can be saved. And finally, they mentioned this study, DNA screen pilot study they have undergone, and which could have some answers to some of those questions. But again, one of the things, the limitation I found in this study, that it's not randomized trial. It's and that could be for me, I found it's kind of a serious limitation, because we won't be able to know for sure if that population-based screening is an effective or not. So what they are proposing is that doing kind of a cohort study, a population-based, and it sounds like representative. They have some methodology to be representative. So population screening for these three conditions, and whoever positive in that screening, they do kind of further testing to make the diagnosis and then informed decision to make any further kind of management for the condition, like risk reduction surgeries if needed. And also they will do some kind of, if for the whole family, for that patient, if it's positive, to kind of screen the family and relative further. But again, whether the evidence output from this study can help us to know whether this population-based screening program is effective or not, that could be kind of discussed now. I think those are the slides from my end.
Thanks, Loai. That's fantastic, and brought out lots. And I think going through those Wilson-Juncker criteria is really helpful, because they're often not really understood when people are thinking about screening, particularly in general populations, people at not elevated risk. I mean, the case that I presented was probably more of a case finding thing in a way. It wasn't a sort of person with no reason to think they might be at risk. It was a slightly different scenario, but we're talking here about a whole. I guess one of the comments I would make, and I'll bring others in here, is doing the study, a randomized trial of this kind of program would be very difficult. I'm interested in John's comments on that. Is that actually feasible to do, John? I mean, we always want to have an RCT if we can, but are we setting in a possibly high bar there to get an RCT of this kind of program?
I think that's such an important question. The biggest challenge, of course, is the low prevalence in the general population of people who carry one of these high-risk variants. And even in these three combined conditions, you've got just over 1% prevalence. And then, so you need to screen a very large proportion to even identify the population who might benefit from some form of intervention. And so, so essentially the evidence that exists to date, as Loai said, is mainly of testing interventions once you've identified those people who are carriers of one of these genetic variants. The majority of those, as you say, are observational studies of interventions. The only trial that I'm aware of in this high-risk population, once you've identified them, is of aspirin versus starch, so the CAP2 trial. But the outcome of that, it was in people with Lynch syndrome, and the primary outcome was incidence of colorectal cancer, so not even colorectal cancer survival or mortality. But that's probably the best evidence there is around randomized trial evidence of interventions once you've identified these individuals who are at high risk. I think it would be extremely difficult to run a full RCT, randomizing the general population to carrier testing or not, and then to be powered on some form of mortality outcome. You'd need hundreds of thousands. Yeah, and so that is the challenge. Yeah.
Anyone want to comment on that point or other points arising from the article at this stage? Yeah, Mark, yeah.
Yeah, I would have thought an RCT is almost impossible for anything that might have a long lead-in time between when you would pick up the risk and when you might see events or prevent events. So I would have thought, practically speaking, anything longer than 5 years, and we start to get real difficulty with running RCTs.
Yeah, can I respond to that, Nick? Is that all right? Yeah, I think that's another important point. Is obviously the DNA screen is in a relatively young population, so they're doing it in 18 to 40-year-olds, and on the basis that particularly for well, I guess all of these conditions, at least a proportion of those people who are carriers, their risks of the cancers that are relevant and of cardiovascular disease events, they start to rise in your 20s and 30s. So that's the justification. But most of them, the incidence continues to rise with age. So it's you would need to be waiting a long time for events to demonstrate that you've prevented sufficient events.
Loai, yeah.
Yeah, I was thinking about that RCT thing and how it's difficult. But how about like quasi RCT or cluster RCT, where you kind of, for example, state. So one state doing that screening, population DNA screening, and another not, and then on the long term, see that. So I was thinking you need some kind of element to compare. Otherwise, just observational study could be biased.
Australia and most states do different things, so maybe Australia's the place to do that. But gee, we'd be waiting a long time for the outcomes, wouldn't we? If we want an outcome like even just cancer incidence would take a long time, and any mortality outcome would take decades, I would think. Paul Dunn, can I bring you in here? You got comments on this as someone who's interested in the world of genetics and genomics?
Yeah, I think from my perspective, one thing that, and sorry if I missed this, but the polygenic factor associated with this in relation to RCTs and everything is going to make it even more difficult for that to come through. So I think it'd be quite difficult for that, as well as the lead-in times and everything else that was discussed prior as well. Because even if they get these things, you know, we can't say for sure that these variants, which are basically risk factors in themselves, typically in the cancer setting, are actually going to be the driving force behind these conditions. But I did find it interesting to note that two of the authors from this paper were heavily involved in the insurance, genetic insurance scheme as well, helping to kind of drive that, which might make studies like this and genetic screening a little bit more prominent in the future without the risk of insurers hiking up prices as well.
So, John, if an RCT is not likely to be possible, and we would like to know whether such a program maybe could have a health benefit, what are the options, do you think, in terms of the research?
Well, I suppose that's, in a way, DNA screen is going down an approach to at least provide you some estimates of various key measures that would go into an economic model, because that is kind of your best next option, really, I think. Albeit, so in some ways, so the DNA screen, they are providing evidence on to some extent participation or uptake, though there's a huge caveat even as to the way they've recruited into this study. So it doesn't really mimic how a screening study, a screening program would look. They essentially went on the TV and social media saying, anybody who's interested, enroll for this study and we'll give you a free genetic test. And they spruik the fact that just on one night of TV and social media, they got their 10,000 sample. But it's they haven't published yet how representative that sample is. It's not going to be a representative sample, I'm sure. If you look at most of these studies where you go for these volunteer approaches, you tend to get very biased, well-educated, to be honest, white females overrepresented. And so it's not really going to tell you that much about the likely uptake in a population screening program. It will tell you a lot about the prevalence of the variants. It will tell you about when those people who identify with variants, the uptake of subsequent genetic counselling, and the uptake of the various preventive measures that they talk about, for which there is an evidence base for these interventions. And they will use that evidence to then model anticipated outcomes. There are some other caveats that I will come to, but I see Mark has got his hand up.
Just before we go to Mark, I guess just to go back to Paul Dunn's point that these genetic things are not the only influence of whether you get cancer or not. I think the point you were making, Paul, that whether you smoke or not, whether a whole lot of other factors influence your chances of getting cancer too. So and as Loai said earlier, the incomplete penetrance that having these genetic variants doesn't mean you will definitely get the cancer. you're just more likely than someone who doesn't have it. So I think that's important as well. Cancer is multifactorial, I guess, in its
I think
yeah.
I mean, obviously we're talking these are quite high risk genetic variants.
Yeah, true.
And there's evidence of polygenic risk that will modify the risks associated with these high risk variants. There's probably less evidence just around how much impact lifestyle factors have in a protective way, because these are relatively high risk genes to begin with. I would like to come back to that point around that uncertainty of the penetrance in a moment though.
Great. We'll go to Mark first. Yeah.
Yeah, I've just got a question about the economics of genetic testing. And if we were to include a much broader range of testing, I'm being controversial here because this is probably not college policy or anything like that, but the personalized medicine approach of using genetic testing to identify who's likely to respond to particular medicines, combined with the high-risk cancer genetics and maybe some others, might start to win an economic argument just through the efficiency of one lot of testing, one database in place where you deposit all the information, and a bunch of specific benefits all combined together. So, John, I'd be fascinated by your opinion about whether we're at that point or we will get to that point.
Yeah, it's a good question, Mark. Obviously, the cost of whole genome sequencing has shot down. So you can now have your whole genome sequenced for well under $1,000. And there is a wealth of information in there, that some of which there is evidence for clinical utility. And in the future, there will be further evidence around clinical utility. And so, as you say, the economic cost of that one-off test, with the future utility of in a range of different areas, will certainly add to that the economic argument of broad benefit. I think you can, in one of the economic models that they refer to in this paper, they have actually included some carrier tests that are relevant to prenatal carrier screening. So SMA and cystic fibrosis. So they're in their economic model, they're already accounting for some of the potential benefit of adding in prenatal carrier tests. And the pharmacogenomics that you mentioned, again, I think there's still uncertain evidence around the cost effectiveness on its own or even let alone the effectiveness of pharmacogenomic testing. We've just been looking at some data on a pharmacogenomics trial in antidepressants, which unpublished, but not looking promising in a general practice setting. So I think, there is that economic argument, but the evidence around effectiveness needs to come first for some of these things.
Highly, yeah.
Thanks. We don't have a population screening program with DNA screening yet, but we know the more things we ask people to do, the less likely they are to do it. And the existing cancer screening programs, for instance, don't ever reach 100% participation. What do you think would be the likelihood of impact on other screening programs? And is the modelling that goes into things like this, does it include flow-on effects on other programs?
I think the modelling, they've assumed quite a high uptake rate of this test in their modelling. They assume about a 70% uptake of this test, which, if you look at uptake in our general cancer screening programs, I think is an overestimate. They don't account, as you say, for the potential consequences of having a negative test, a genetic test, on subsequent cancer screening. And I think that is an interesting outcome. So because are you creating false reassurance? And therefore that might impact on broader population screening. It's an interesting question. And so there are lots of, there may be some unintended consequences on population screening participation that that need to be considered in this.
Any other comments before we go back to John on that question of penetrance of these genetic things to actually going through to causing the cancers? Anyone else? Stage. Feel free to turn on your cameras if you wish to, so we can see who's out there. So John, maybe we'll go back to you on that issue about penetrance.
Yeah, so it comes back to as in the classic Nielsen and Werner criteria around understanding the natural history. And so the penetrance estimates of, for example, BRCA mutations were initially higher because they were enriched by families who had very strong family histories. And so a lot of the studies around the impacts of various preventive measures are based on data who have been identified because they have very strong family histories in the first place. So you have a kind of an ascertainment bias in that a lot of those early studies of families have been enriched by carriers who have a very strong family history. And so the penetrance estimates were probably higher. When you then start doing population testing, you identify individuals who are carriers who may have much less family history or no family history. And there's studies coming out from various biobank projects that show that the penetrance is affected by your family history. And so that if you have less significant family history, then your actual cancer risks are less, which kind of makes sense if you think about it. But it means that actually how you cancel people who are identified in a carrier screening program who may have, limited family history, they certainly won't have necessarily those classic family history that you see in the Red Book that are criteria for referral for genetic testing. It's much harder from the genetic counselor's point of view to know exactly what risks to suggest that somebody actually has. And so the absolute benefit from some of these interventions, particularly in the sort of breast ovarian space where you're considering prophylactic surgery, whether that's oophorectomy or mastectomy, those are significant interventions. And if you're overestimating the underlying risk of breast and ovarian cancer because you're using penetrance estimates that have come from populations that are enriched by family history, then you start to run into problems. And so that's something that I don't think the people in the DNA screen program have really wanted to consider. Certainly when I talk to other clinical geneticists, they worry about this because they are left to deal with the carriers that are identified through a carrier screening program. And it is much harder to know what risks to provide. If you found somebody who's a BRCA1 carrier, but they either come from a small family or they come from a family where there's only one affected first degree relative, and you really don't know quite what to suggest their risks may be. It's probably less of an issue with Lynch. You still get the same issues around the penetrance being less, but the interventions that you're offering are probably less harmful. You're essentially putting people on a colonoscopy program. Not that that's without risk, but it's a different level of intervention to prophylactic surgery. So I think it's a really important part of this whole mix of how you actually know what the true risks are when you do population screening.
That's interesting, John, because as I was saying just before we opened up the meeting, I happened to be in Melbourne last week and listening to a lecture by Professor Paul James, who's one of the authors on this paper we've been looking at. So I sidled up to him afterwards and admitted I was on the Red Book committee, and he knew what the Red Book was and said, we're going to have this journal club. And basically, what did he really think? And what he said was he wasn't sure that the risk the risks of getting the condition from the people you would find by this population approach were as high as the sort of people actually you see in a genetic clinic, which I think is more or less the same thing you're saying.
That's the point I'm saying. Yeah.
But he still put his name to the paper, so that was interesting. Reminds me of that saying about consensus, that consensus is when a group of people agree to do something collectively, which none of them would do individually. But anyway, okay, opening up for other comments.
Do you think AI will be able to give us some kind of, or will it be able to replace, or will it be able to tell us the estimate of a person developing cancers? Now we know that we have some precision health platforms called Shay, so they can give us a lot of information regarding the best diet, the best exercise, the best place you will suit you to live. So do you think the AI will be able to predict cancer risk too?
I mean, it can do for certain data sets already. And there's a lot of interest in using AI with data that's in the electronic medical record to predict risk of cancer. And there's some early examples where that might actually have applicability. Eventually, if the world that Mark suggested, where we all also have our whole genome sequence sitting somewhere in the medical record, that will be part of that. Yeah. In terms of the longer term there will be these models running in the background that incorporate genomic data, medical record data, and probably all sorts of other data on you that it's obtained that could be used for that purpose.
Just a comment on that, John, I guess it's in the public domain, so I think it's okay. There was a certain famous actor who lives down Byron Bay called Hemsworth, I think, Chris Hemsworth. I think some would have heard of him. He's been in a few films, and he took part, I think, in a National Geographic show about healthy lifestyle and well-being. And he had his genome done and found he was at greater risk of early onset Alzheimer's than most. And I don't think there's anything he could do about that, but he had to take some time off from his film career because it was really quite affecting for him, apparently. So, I mean, I guess that there are unforeseen consequences, aren't there, of these sorts of things?
Yeah, there really are. And particularly, I think that was the FOE alleles he had picked up from memory. And yeah, for things like dementia, where we don't really know what preventive interventions there might be, then it comes back to what Loai was talking about earlier. You need some effective interventions if you're going to identify these risks. So I think for the dementia genetics, that's still the problem. I think for the ones that are listed in this paper, it's not that there's an absence of interventions to offer. I think there are just lots of other things that are problematic.
How far away is AI from predicting our risk of cancers? If it is not too far away, is it worth rolling out the national genetic screening programs for detection of cancers?
Oh, that's a different question, really. I think we're a long way away from that around I think even in the context of this paper that we're talking about today, I think there's sufficient uncertainty around population screening just for these 3 hereditary conditions. I'm not sure AI is going to help us with the answers that we're talking about specifically today.
Loai and then Paul.
I was following from that really interesting discussion from Kylie about the unintended consequences of those screening program, not for those who have been tested positive, but those tested negative, and the possibility that they're more likely to do more risk taking behavior. Like if they are tested negative for cancer, more of that kind of they feel like assured that they are not getting cancer. I don't know if that could be a reality or not.
It's so much that they may take more risks. It was more they might not bother with, say, then having 2 yearly fecal occult blood because they think, well, I don't have Lynch syndrome, therefore I don't need to bother to, when the government sends me that little birthday present, to bother doing it. Though I guess there's a small risk, but but I think that was more what you were getting at, Carly. I think, yeah.
I suppose I want to jump on with the AI and the screening and risk thing. One other component that I think was touched on briefly is the limitations in a lot of our genetic information is related to people of European descent. We've got really strong data for a few select conditions related to that, but once we start looking at different nationalities, ethnic groups and things like that, and that's really having a massive effect on what we're doing. Polygenic risk score testing at the moment is one of the latest hot topics in terms of this area, where basically taking GWAS data, coming up with these scores to say this is going to predict your risk of this condition or that one. And again, and some of this is AI driven and everything as well, but again, they're finding that because we've got a lot of data from the European descent, in some cases it works really well, in others it's basically useless. And you should basically just go back to your basics in terms of clinicals, family history, looking at the targeted things instead. So just something else to consider with a lot of these screening tests that they didn't really touch on in the article from what I read either.
Yeah, they kind of avoided polygenic risk scores altogether, and have just gone for the high risk variants in single genes. And you're absolutely right. The polygenic risk areas is fraught by those issues of ancestry and the fact that they certainly don't perform well in people of African origin, certainly the cancer ones. And for some of the, for Asian populations, there's sort of some evidence that they perform reasonably well, but not as well in European populations. So there, there's a whole body of work that needs to be done to develop and calibrate PRS in other ancestries that are relevant for Australia.
John, in a few minutes, we'll go back to the sort of slides from the Red Book and kind of start to wind things up. But what about case finding? Because I think Paul James was making some very practical observations, I think, about at that lecture that he got into about when we should be alert as GPs and we're taking a family history of people maybe have a higher risk, and things like age 45 is a bit of a cutoff for earlier onset cancers, which cancer sort of groups tend to cluster. Do you have comments on that sort of,
Yeah, I think family history is still really useful, but underutilized in general practice. That's still, I think, the preferred way to identify people who are likely to be a carrier of a Lynch or a BRCA mutation, and identify those who are more likely to benefit from referral to genetic services for consideration about genetic testing. You have fewer problems around this uncertainty of penetrance, and it's a more targeted strategy. But as the paper says, it's not working because there's still an under recognition of people who, even with high risk families, are not being recognised and offered referral. And so general practice does actually have a really important role there to identify those people who meet the family history criteria for Lynch or for BRC1 or 2, and there are separate criteria which are again phenotypic criteria for familial hypercholesterolemia as well. So I do think it's I mean, I've been banging around about this for more than 20 years around just actually using the family history better to identify these high risk families. And it's problematic because we don't have a good way of recording it in the EMR. And that's part of the difficulty. There is in the Red Book a simple screening questionnaire that could be used to systematically identify people with significant family histories. I would quite like to talk about your case at one point.
Yeah, we're going to come back to it in a minute. So we might just look at those Red Book slides, and John will go through those. I think we've got some of the relevant ones that Ali will bring up. Red Book saying about when to be.
Is that visible?
Yeah, so routine population-based genome-wide, not recommended, and I think we probably would stick with that recommendation despite the advocacy from this group. So the next one, thanks, Ali.
So that's quite a specific one. Actually, that's more to do with pediatric conditions.
Pediatric conditions, yeah, sorry.
No, that's right.
Yeah, and this is for breast cancer, women at potentially high risk carrying mutation, referral to familial cancer clinic, and increased surveillance and risk reduction. Anything you'd like to say about that one, John?
Yeah, I mean, these are obviously some of the interventions that are mentioned in the paper that would be offered to people who are identified as a BRCA 1 or 2 carrier. It's really about, as I was saying, trying to identify those people who meet the family history criteria and offering them referral.
One is bowel, I think. Ali, we might go to the next slide. So colorectal cancer, people at moderately increased. You start younger than the diagnosis, 10 years, 10 years younger than the earliest age of diagnosis in a first degree relative, or over 50 or age 50, whichever's earlier. And then Lynch syndrome, colonoscopy. So there's the recommendations. As John's saying, though, you've got to actually have asked the questions and worked out that they are at risk. Otherwise, you won't think to offer this. And I think we've got one more, haven't that slide, I think, Ali, have we? And then there's some more about the colorectal cancer risks. And it's quite detailed, isn't it, John? That's one of the struggles here.
That is part of the problem, particularly with Lynch syndrome criteria. There are multiple cancers, and so sometimes it's about making the link between colorectal cancer and other cancers that are associated with Lynch, and there are lots of them. And that's, if you look at the bottom, all the list of cancers that are associated with Lynch that you need to think about. So if you see somebody with colorectal and endometrial and stomach or ovary, you know, it's these odd clusters of cancers that you need to be also looking out for, because it's not just about multiple colorectal, but it's difficult to remember all these different cancers that are associated with Lynch.
I think there are some patient-facing tools now, aren't there, John, that people can kind of put in and get a risk score. And we'll circulate some of those in the after to the group. Have we got any more slides, or is that it, Ali? Some resources. So these are a couple. There's this EVIQ. John, can you tell us a bit about that? It's one of the.
So EVIQ is it's a New South Wales resource. There's an awful lot around cancer treatments in there, but there is also a section around cancer genetics and again guidelines of referral for people with family histories for genetic testing, and that it extends beyond some of the cancers that are in that we've just mentioned. So other family history that's worth looking out for.
And Ali will send around the slides. I think Cancer Council Victoria have some resources as well, or Cancer Australia maybe, John, which we could add.
Yes, they certainly used to have one around familial breast and ovarian cancer, and it may be being updated. Yeah.
Well, shall we go back to the patient and interested in John's view? I don't know whether Ali can whiz back through the slides, or we can just remember the patient, the 51-year-old man who had a brother diagnosed with colorectal cancer age 59, and because it was the United States, of course, you know, we shouldn't be prejudiced, but where medicine can get out of control very easily, there were all these suggestions about what further should be done. What were your thoughts, John? What would I say to my patient?
It's kind of a really interesting example because, well, so the first thing to say is that obviously prostate cancer is not one of the cancers in the Lynch syndrome, so you don't need to worry about that. In the previous Red Book, so Red Book 9, just with that family history, so one first-degree relative aged 59 at diagnosis, he would have been counted as at near average risk. And so would have just been recommended twice, biennial FOBT testing. The guidelines have changed very subtly in the new Red Book. And so that the age of onset in a first-degree relative that puts you at moderate risk has moved up to 60. So he would now be considered in the moderate risk group, but he wouldn't have been in the previous Red Book. So he would now be recommended colonoscopy. And it's this whole thing about you start 10 years before the youngest onset relative. So he would now be suitable for colonoscopy according to the Red Book. He certainly doesn't meet family history criteria for Lynch syndrome, though.
Right. Interesting. So that very practical implication there for this patient, which I'll have to talk to him about.
Well, it's interesting. I don't know when you saw him. You were very consistent with the Red Book 9, but now you're going to go and tell him something different from Red Book 10.
I saw him before Red Book 10 came out, I'm pleased to say. So I was consistent at that time with the guideline. Yeah. And I think an important point that John makes there is the prostate cancer diagnosed at age 78, that those two cancers are not related. They're not part of that Lynch cluster. And in terms of PSA
testing, I guess, that doesn't really put his risk up very much at somebody at that age.
Yeah. So he hasn't got a young age prostate relative. Another thing that Paul James said, interestingly, I hadn't heard so, is that a sibling is probably having a cancer in a sibling may be a higher risk of you getting the cancer than a parent. Has he got comments on that, John?
Yeah, I think there is some evidence around that. And I know for prostate cancer, particularly while we're talking about it, there is some evidence that actually having a brother diagnosed with it, and particularly before the age of 60, that may be associated with a higher risk than if it was your father. It's not perfect evidence. And at the moment, I've actually just been trying to get the Red Book modified, because at the moment it does just talk about a brother before the age of 60, and I think it needs to be a father or a brother. But there is sort of, I think the evidence is probably still that we should count any first-degree relative aged before 60, where you would just prompt a discussion around PSA testing at a slightly earlier age. Then that's all it is. Yeah.
We've only got 4 minutes left. Any other comments, questions, or we can probably stop? I know there's a couple more slides, aren't there, but wind things up, Ali. But any other comments or questions or thoughts before we kind of just to do a bit of a wrap up of what else is on offer through the Practice-Based Research Network? I think it's been a fascinating discussion. So we've got a couple of other projects on at the moment. This is about the Handbook of Non-Drug Interventions, something that's very close to Paul Glazio's heart, who's not with us tonight, but otherwise would be. And there's a study about the feasibility and acceptability of co-designed e-handy, so trying to make the handy thing that's currently on the RACGP website something that's available in an app type form. I think I'm right, Loai, and that's the idea, and something patient facing as well as clinician facing. Am I right? Am I wrong about that? Sounds I'm right enough. So anyway, that study's happening at the moment. So if anyone's interested, scan the QR code and the slides will come out. So it'll be on that as well. And I think there's another one, isn't there, that we're doing at the moment? Oh, very relevant. Cancer survivorship in general practice. Kylie Vong, who's one of the people contributing tonight, is one of the researchers on that. Joel Ree from UNSW, a former PhD student of mine, I'm proud to say, and Thornton Benko. So that's another one as well. And is that it, or we still got more projects? No, that's it. And if you're not a GoldNet member and you'd like to become one, there's another QR code you can scan, or you can just contact Ali, who's behind the PBRN, GoldNet PBRN email address. Ali, anything else before we close? Any housekeeping that I should have covered?
No, that's it. Other than, you know, if you've got topic suggestions for 2025 events, so we do the 2 face-to-face and 2 online journal clubs a year. So always open to suggestions of practice questions or research or hot topics that you're hearing and seeing in practice. We would love you to email us, and I'll send all the resources that we discussed tonight and the slides as well.
Well, thanks so much, John. Thanks so much, Loai, everyone who's come along. We've got 2 minutes left, so you've got 2 more minutes in your evening than you thought you did, isn't that? So use them wisely, and we'll see you at a GoldNet event in 2025. Thanks, everybody.
Thanks.
Can I
Thank
just add?
you.
Bye.